So today our table of content is introduction, mechanism of action, causes, diagnosis and management of heparin resistance. What is heparin resistance? As the name suggests, when we fail to achieve adequate anticoagulation effect despite of administering adequate or higher levels of unfractionated heparin. In cardiac surgery, patients going under through CPB requiring more than 500 units per kg of heparin to achieve anticoagulation ACT of more than 480 seconds. What is heparin? हेपरिन है क्या? हेपरिन नेचुरली अकरिंग ग्लाइकोसअमाइनोग्लाइकेन एक हेट्रोजेनस मिक्सचर ऑफ सल्फेटेड पॉलीसेक्राइड्स है जो कि प्रोड्यूस होता है मास्ट सेल्स एंड बेसोफिल सेल्स से, जो कि एंटीकोगुलेशन इफेक्ट प्रोवाइड करता है. कैसे? बाय बाइंडिंग थ्रू एंटीथ्रोम्बिन 3 जो कि एक नेचुरल इनहिबिटर ऑफ ब्लड क्लॉटिंग एंजाइम्स है. मैकेनिज्म ऑफ हेपरिन. हेपरिन बाइंड करता है एंटीथ्रोम्बिन 3 से फॉर्मिंग हेपरिन एंटीथ्रोम्बिन 3 कॉम्प्लेक्स जो कि क्या करता है, थ्रोम्बिन को फैक्टर 2A को फैक्टर 10A को इनहिबिट करता है. फैक्टर्स 2A 10A ये क्या करता है, फिब्रिनोजन को कन्वर्ट करने फिब्रिन में से इनहिबिट करता है और जो थ्रोम्बिन है वो नहीं प्रोड्यूस होता, जिसकी वजह से ब्लड क्लॉट नहीं होता. As you can see in the first picture, हेपरिन जो है वो सप्रेस करता है थ्रोम्बिन के एक्शन को, इनहिबिट करता है फैक्टर्स को लाइक 2A, 11A, 12A, 10A और एंटीथ्रोम्बिन 3 की एक्टिविटी को एक्सेलरेट करता है, कैटलाइज करता है. अल्टीमेटली ये सब चीज़ें प्रिवेंट करती हैं ब्लड क्लॉट फॉर्मेशन को. एंड इन दैट पिक्चर यू कैन सी थ्रोम्बिन जो होता है वो फिब्रिनोजन को कन्वर्ट करता है फिब्रिनोमर्स में, मोनोमर्स में, जो कि फिर फिब्रिनोपेप्टाइड्स में कन्वर्ट होता है जो कि फिब्रिन प्रोलोफाइब्रिल प्रोड्यूस करता है जो कि क्लॉट फॉर्म करता है. तो बेसिकली हेपरिन इस मैकेनिज्म को इनहिबिट करता है प्रिवेंटिंग ब्लड क्लॉट फॉर्मेशन. कॉजेज ऑफ हेपरिन रेजिस्टेंस. अब हमने हेपरिन एडमिनिस्टर की लेकिन पेशेंट में ACT इंक्रीज नहीं हो रही, पेशेंट में हेपरिन रेजिस्टेंस है, तो व्हाट कैन बी पोटेंशियल कॉजेज? आइदर पेशेंट में एंटीथ्रोम्बिन 3 की डेफिशिएंसी है, पेशेंट के प्लेटलेट्स एक्टिवेटेड हैं जिसकी वजह से प्लेटलेट फैक्टर 4 रिलीज़ हो रहा है जो कि हेपरिन के साथ बाइंड कर रहा है और उसको न्यूट्रलाइज कर रहा है. पेशेंट के अंदर फिब्रिनोजन एलिवेटेड लेवल्स हैं जो कि हेपरिन के साथ अगेन बाइंड कर रहे हैं और अवेलेबिलिटी उसकी रिड्यूस कर रहे हैं. या फिर प्री ऑपरेटिव पेशेंट को इन्फेक्टिव एंडोकार्डाइटिस या हाइपोएल्ब्यूमिनीमिया है जिसकी वजह से पेशेंट के एंटीथ्रोम्बिन 3 डेफिशिएंसी होती है, या फिर पेशेंट की हेपरिन क्लियरेंस एंड मेटाबॉलिज्म इंक्रीज्ड हुई है. Further, Aitzaz will tell you about diagnosis and management of heparin resistance.
Assalamu alaikum. My name is Aitzaz and I'll further continue. Starting with the causes. Resistance is mainly caused by usually two mechanisms. The first one is either heparin gets consumed or either it gets cleared. Now, how heparin is consumed? There are different mechanisms. The first one is antithrombin 3 deficiency. Now, antithrombin 3 deficiency is of two types. There is type 1 and there is type 2. In type 1, there is not enough antithrombin 3 so that heparin could act upon it. The second type, there is adequate levels of antithrombin, but which is not effective enough to combine with heparin and cause anticoagulation. Then we have platelet factor 4 release from activated platelets can bind and neutralize heparin, reducing its efficacy. As we know, we are utilizing extracorporeal circuit. There is activation of platelets already. So they release platelet factor 4, which again is a protein, and proteins have ability to bind with heparin and neutralize heparin as there is no site for antithrombin 3 binding. So this specifically this part of the presentation or release of platelet factor 4 is initiative for heparin induced thrombocytopenia. Second, elevated levels of fibrinogen and plasma proteins. As I mentioned, that whenever there is a protein inside plasma, it has efficacy or it has efficiency to bind with heparin. So again, if we have higher levels of fibrinogen levels, it can bind to protein, and again it neutralizes the heparin available in your circulating blood. Moving on to the next point, increased heparin clearance and metabolism. Now it is of core importance that heparin is cleared more than gets metabolism and metabolized. It is cleared again through binding with plasma proteins through renal pathways. Then we have some conditions. For example, if we have a patient who has been diagnosed with infective endocarditis and he is on bypass. Now what happens during infective endocarditis is that the patient is hypercoagulable, he has hypercoagulable state. So the available antithrombin 3 that the patient has gets utilized already in treating the hypercoagulable state. So again the heparin is being used, or antithrombin 3 has been completely used. Diagnosis can be done through various methods. Either there is lab test, but the direct indicator of diagnosing there is heparin resistance is failure of rise of ACT to adequate range, which is 400 to 480 seconds. If we move towards the lab tests, there are certain lab tests starting from heparin levels. We can check heparin levels in circulating blood, which is 4 units per ml. Then there is antithrombin 3 activity. This is a very specific test to check antithrombin 3 to differentiate between type 1 and type 2. There are two tests, the activity assay and the antigen assay, which can differentiate between type 1 and type 2. Moving on, anti-factor 10A assay. This is again a test used to measure the clotting factors, especially 10A in circulating blood. Then there is APTT. APTT is considered the gold standard when you are using unfractioned heparin during cardiopulmonary bypass. Then chromogenic and clot-based assay test. These are again similar to the factor 10A assay test, where you can calculate or measure the circulating clotting factors. Management. Once you have diagnosed that there is heparin resistance, you move on to managing the heparin resistance. There are 3 basic steps. The first one is antithrombin 3 supplementations. This is done preoperatively when a patient is diagnosed preoperative that he has antithrombin 3 deficiency. Then there is antithrombin 3 concentrate and FFPs. These are therapies which are done either before the bypass or during bypass to replace the clotting factors, or especially antithrombin 3. This is a detailed algorithm which can be utilized during bypass to counter antithrombin 3 deficiency. First, we have the problem that we have low antithrombin deficiency and there is failure of rise of ACT during bypass. So we can manage it for low AT levels, antithrombin 3 levels, for normal antithrombin 3 levels, and for normal antithrombin 3 levels with heparin levels which are normal. For low antithrombin 3, we can either give supplementations pre-bypass, which is 500 to 1000 units, or we can get therapy for the patient, which is giving antithrombin 3 concentrates during bypass. If it again fails, we can repeat the doses and check for ACT until we are clear of our ranges, which is 400 to 480. Then for normal AT means the ACT is on its baseline and it's not rising to 480, 400. So we have to administer a higher dose of ACT, higher dose of heparin until we get our target range, and we have to recheck the ACT levels again and again. And then if we have normal AT and normal heparin levels, again after administering the adequate level of heparin, we can move further to clinical judgment or what the surgeon decides further. At last, what is importance of adequate anticoagulation? As we all know that we are utilizing a CBP circuit, and blood is susceptible to clotting, blood is susceptible to histamines, blood is susceptible, or the patient is very much susceptible to infections or inflammations. So adequate anticoagulation prevents these risks, which are thromboembolic events and stroke, which is of most important to highlight or to manage post-operatively. Then balance anticoagulation to minimize both clotting and bleeding risk. Now we not only use heparin to prevent clotting, but we also use it to balance the clotting and bleeding risk, because at the end of bypass we again reverse it by protamine. So it is of basic importance that you balance the clotting and you balance the anticoagulation mechanism. This is from our side, and thank you for listening. If anyone has any questions, you can ask. Yes, sir.
Very good presentation.
Thank you, sir.
All the things you shared with us, excellent. One thing I would like to add, जैसे आपने बहुत सारी चीज़ें बताई, ACT अगर नहीं अचीव कर पा रहे तो क्या क्या करना है हमें. One thing which I think miss in this slide, अगर ACT नहीं अचीव कर पा रहे आप, तो सबसे पहले जो हमने एक्सपीरियंस किया अपने प्रैक्टिकल उसमें, ACT के कार्ट्रिजेस को सबसे पहले देखें कि कहीं एक्सपायर तो नहीं है, डैमेज तो नहीं है. फिर आपकी जो ACT मशीन है उसका क्वालिटी कंट्रोल टेस्ट होता है जो हर सुबह होता है. वो मेरे ख्याल से इसमें ऐड कर लेते तो, क्योंकि हमारे साथ ये हो चुका है एक्सपीरियंस कि हम हेपरिन दिए जा रहे हैं, जब हमने दूसरी मशीन पे लगाया, कार्ट्रिजेस चेंज किए तो हमने अचीव कर लिया. हाई 99 मतलब 999 से भी ऊपर चली गई, हाई रेंज चली गई. तो ये चीज़ थी. बाकी एक्सीलेंट. थैंक यू.